Hi, I'm going to talk to you about the sports physical exam today. Fortunately, my iMovie skills aren't that great, so you're going to be looking at me most of the time, but I have some help, okay? So, I'm going to focus today on the red flag sections of the sports history and sports physical, because I think this topic is actually pretty large and that really it'll take at least an hour to really go through all the sections in detail. The other thing is that there are certain things that I think are important to remember and do every time, so I'm going to focus on what those things are. And I will refer you to the 2011 Peds in Review article, where I got most of this information, to get all of the details that you really need to know for the sports physical exam. Okay? The number one thing to do is to make sure that you have your patients in an adequate amount of time so that you don't feel pressured to just sign the form and get them out because they're starting their sport tomorrow, but more importantly, that you have time to do any follow-up that may be necessary. Apparently, only approximately 5% of kids even need further evaluation, and only about 1.5% actually get restricted from sports. But, it's an important part of our practice as pediatricians. You need at least 6 weeks prior to the start of the sporting event in order to have enough time for follow-up and any necessary tests or anything like that. So what I've started to do actually is tell my patients, if I see them, at a general well visit sometime in the winter, to come back in about 6 months for their sports physical. So remind them whenever I see them that, oh, you play sports? Well, make sure you come back for your sports physical, unless they say that they get their sports physical someplace else. Now that we've got them in ample time, we have to make sure that we focus really well on the history, because most of what is going to be relevant and helpful to us is actually going to be found on the history, okay? So we have to bring in our patients with their physical history form already filled out. So there's two reasons why we need the history form to be already filled out. One is that on the form it says you as a physician have reviewed the history form. You have to sign that. If there's no history filled out, then obviously you can't, in good ethics, sign that part of the form. But more importantly, it's helpful to have all of that information already filled out, because it saves you some time, because there's a lot of relevant pieces of the history that are addressed on that form, but also it helps you to focus your physical and focus your questioning. So if there's anything on the health exam and the health portion of the form that says yes, then you can ask more specific questions. So for example, if they say yes, they've had a musculoskeletal injury in the past, you can say, what joint was it? Did it require casting? Did it require imaging? How long were you out? How many times have you injured that joint? Things of that nature. So anything that's a yes, you can focus in on those questions and get more information so that you can do an adequate both history and physical related to that particular question. Things that even if the patient has circled no in that part of the history, that I make sure that is an actual no. So in the cardiovascular section, I make sure I ask again about their family history of sudden death, heart problems, ages of people with heart problems, things like that. I always ask about concussion, even if they say, no, I've never had a concussion. Have you ever been hit in the head and then felt foggy, or that you had memory loss, or that you had sustained headache after that you had vomiting, that you lost consciousness. Now remember, most concussions don't result in loss of consciousness, which is why you have to ask all of those other questions, okay? So if you have somebody that has a history of prolonged symptoms with concussion, you have to then ask how many times has this happened, etc. So I always ask about concussion because it's so common, and it's also very common. I saw one statistic that said up to 50% of sports-related concussions are not actually reported. I'm sure that number is lower now that we're making a bigger deal out of concussions, but knowing that a lot of concussions will never have been diagnosed, you have to make sure you ask about more specifically about those kinds of questions. The other question that I always ask in the GU department is any history of hernias for boys and girls, because anybody can have a hernia, and any history of groin pain, which would be obviously a proxy for hernia, any changes, bulging, anything like that down there. And for girls, I ask them about their obviously menstrual history. Do you menstruate regularly? What was the first day of your last menstrual period? And of course, as a future adolescent doctor, I always ask, do you think you could be pregnant? Obviously, an important pathology for sports participation. Other questions that I find very important are questions such as, do you have a special diet, or how do you manage your nutrition while you're playing sports, which is sort of a secret way of screening for any disordered eating, especially in patients who are doing a sport related to weight. I'll ask them what's their current weight and what weight class, like for wrestling, for example, what weight class they plan on competing in. For example, I actually had a kid a few days ago who was wrestling, and he's 220 pounds and wants to wrestle in the 200-pound weight class. And I asked him what he was doing to lose that 20 pounds, and he said he looked up on the internet how much calories he should eat for his size, and then he halved it. And he drinks 2 cups of water a day. Okay? So he had no idea how unsafe this practice was. And so talking about that opened the door to sort of counsel him on nutrition and healthy weight loss in an athlete. And he was practicing 2 times a day, and it was just, I'm surprised he hadn't passed out by then. There are a few conditions that are pretty much absolutely need to go to the cardiologist per this article from Peds in Review. And those are any cardiomyopathy, any coronary artery disease, including history of Kawasaki's disease, any myocarditis, any kind of congenital heart disease, any kind of channelopathies, including those that present as long QT syndrome. So if you have kids with this history, they should be cleared for sports by cardiology and not by primary care. Now, regarding the review of systems, there are a massive amount of questions that you should ask, but I'm going to hit the ones that are most relevant, most important, okay? So in the neurologic section of the review of systems, you ask if they have headaches with exercise. You ask if they have any numbness or tingling anywhere, because these can all be signs of nerve injury or previously undiagnosed concussion, etc. And then you can go from there. In the CV department, you absolutely want to ask about syncope, near syncope, chest pain, palpitations, shortness of breath with exertion that is extreme, and you need to tease out the difference between, in the syncope portion, between post-exertional syncope, which is common and benign, versus exertional syncope, which is dangerous and should absolutely be evaluated with at least an EKG. Okay, so if they say that they pass out after they're finished exercising, when they're cooling down, then that can just be from pooling of blood and they just pass out. But if they pass out in the middle of their run, that's ominous and they need to be evaluated right away. It's been shown that musculoskeletally, if you ask the following questions, you're going to be able to find most, greater than 90% of musculoskeletal relevant injuries by asking if they have any current injuries, if they have any history of injuries that resulted in them having to go to the doctor, or if they have any history of casting, bracing, or surgery. And again, that's sort of like history / review of systems, but current injuries, current pain, current limitation to movement, and any history behind any of those things will get you most of major historical things regarding past medical history that are pretty common is one, if you have a history of epilepsy and you are well controlled, as in you haven't had a seizure in greater than 3 to 6 months, then you have no restrictions. If you have had seizures and you're not that well controlled, then you can still play sports, but there are certain sports that you should not play, and they include things that can cause injury to yourself or others, for example, archery or rifling or contact sports such as football. And there is a list in the little handout that I made for you guys of what those sports are for epilepsy. If you have Down syndrome, obviously you can play sports, but there are you have the risk of atlantoaxial instability. So you can do imaging to see if there's atlantoaxial instability, but oftentimes people will develop atlantoaxial instability and will have it despite previous signs or symptoms on or signs on imaging. So the recommendation is no collision sports for anyone with Down syndrome. Now, if you have documented atlantoaxial instability and you have Down syndrome, then it's recommended that you have you do not participate in neck stressing activities such as certain types of swimming, soccer, etc. And those are listed again in your handout. The other specific medical condition that is common that you'll see regarding sports is diabetes 1. Obviously, we have lots of athletes that are diabetic. However, there are recommendations, and I don't know how scientific they are, but in the paper it was recommending that you have them take their blood sugar every 30 minutes or so during the sustained exercise and about 15 minutes after that. Asthma is obviously the other big health history condition, distinguishing between exercise-induced asthma and regular asthma is important because exercise-induced asthma classically does not respond to controller medication, so all you need to do is make sure they have plenty of albuterol at hand and they have an asthma action plan that tells them when they should take their albuterol prior to practice, prior to games, and making sure that somebody has the inhaler with them at all times, or the student themselves has the inhaler with them and not in their locker. Other ones that I thought were very important, though not as common, include cervical cord neuropraxia or transient quadriplegia. Now, this isn't a condition, but it's something that can happen to people and is something that you usually elicit on history. So this is when you have some kind of trauma to your cervical cord region and it results in transient quadriplegia, and it's from transient compression of your spinal cord. So you might lose control of your arms and legs, you may or may not have sensory systems, and it lasts anywhere between 15 minutes and 2 days, but it usually goes away. If that only happens once, then it's okay. But if it happens multiple times, then there needs to be an evaluation of the patient's cervical spine. Before you even start the exam is the vital signs. Obviously, you're going to have people who have low resting heart rates, but you have to take everything in context. So, for example, bradycardia can be a sign of an eating disorder. So, if you have a girl or a guy with a very low BMI who has signs of disordered eating, who, when you do your exam, you see caries or perhaps discoloration to the fingers, or disordered menstrual cycle on your history, then it's worth doing further investigation for eating disorders. They have severe hypertension, which is greater than the 99th percentile for age and height, +5, and they're systolic, and then those people need to be evaluated. Those people need to be removed from high axial load sports, which include anything that results in you flexing your muscles but not moving them. So that's weightlifting, wrestling can be considered a part of that as well. On to the exam. So now that you have a good health history, so Boston's mom tells me, oh, he had a broken ankle a year ago. It was in a cast for 6 weeks, but now it's better, and we got a repeat x-ray and everything is fine. Other than that, he has no medical problems, and life is good for him. Oh, wait. When I asked if he took any medication, she said, oh, he takes Adderall for his ADHD. Oh, he does have ADHD. Right, forgot about that. So, Mom, thank you for the information. So, what we do is we talk about the fact that ADHD is a stimulant. Some people abuse it in order to increase their performance on the field. Would you be willing to try a non-stimulant medication? This is a very complicated conversation, and again, you would have to document that this patient medically needs these medications, and if by chance random drug testing were to occur, that they are taking it for a medical reason. So we also know that he had this history of ankle injury, so I asked him, Boston, do you have any ankle pain anymore? No, sometimes it gets stiff, he tells me. Okay, great. So I have that all in mind as I do my exam. So first of all, I'm going to review his hearing and vision test. Hearing test is awesome. Vision test is 20/60 in one eye and 20/20 in the other eye. Oh no! Boston, you need to wear protective eyewear because anything worse than 20/40 is considered functionally one-eyed, and you need to protect the eyes just to make sure that you don't lose the other one in some kind of sporting event. So Boston here wants to play basketball, so I'm going to tell him to wear protective eyewear since one of his eyes is functionally not functional. Okay? So now there's no family history that I should be worried about, no shortness of breath, no syncope. So when I do my exam, I'm going to make sure that I listen, and I, for one, again, everybody's different, but I, for one, always do lying, sitting up, and a Valsalva to make sure that I don't hear any murmurs, and I do not. I do the rest of my exam pretty briefly, make sure that if I can feel any kidney, make sure that there's no masses there. Now, he's ready for his GU exam because he's not wearing any pants here. However, from what I saw in the paper, the recommendation is not to do a GU exam for hernias unless he has symptoms. So he's never complained of any groin pain, never complained of any bulges down there. I take a quick look to make sure that he's at an appropriate Tanner stage, and that nothing looks abnormal grossly, and then I put him away, okay? I don't have to do that hernia exam per what I read unless there are symptoms. And as one source put it, hernias are not subtle, So if you have one, it will usually show itself in some way that will lead you to investigate it further. So then I check reflexes, and then I go through my musculoskeletal exam. So again, there's actually not that much evidence to support usefulness for this pre-participation physical, but I like to assess them through range of motion just to make sure that there isn't anything that they're not telling me about. So I have them go through range of motion in the upper extremities, moving all of their joints as much as possible, move their head around, make sure they can go through the full range of motion without any restriction or signs of discomfort, have them bend forward and back, have them bend at the waist, have them hyperextend at the waist, check for scoliosis as I would normally do, check again for lower extremity and at each joint. And because he's telling me he has this history of ankle injury, I'm going to do my normal range of motion. I'm also going to make sure that I do strength testing, if there's a, check his Achilles reflex, have him, if there's any, check any ankle drawer signs or do any other special testing that I might deem necessary, paying attention to any signs of restriction to passive motion, resistant active motion, appropriate reflexes, etc. So then I can sort of hone in on the joint in question without having to do the same exam on every joint. And then after you finished your history and physical, just taking the opportunity, if you have the time, to really talk to them about anticipatory guidance, and especially with teenagers, you have to make your anticipatory guidance egocentric. So if you don't tell me about for example, if you don't tell me, Boston, that you have an ankle injury in the future, then you might end up having to be out longer because you didn't protect your leg, and your future career as a basketball player might be in jeopardy. Or if you don't tell me about your concussion, then even if I have to take you out of sports, the point is not to take you out of sports forever. The point is to take you out of sports for now so that when you go back, you're a smart and focused player that's better than the other player. So that concludes my presentation. Please see the handout that I sent you for random tidbits of tables and whatnot. That'll be helpful to review the high points of the physical, sports physical, and see you next week.